Anatomy of the abdominal viscera, foregut and derivatives. Why do you want to study the foregut and its derivatives? Well, you need to be aware of the position of the abdominal viscera in order to perform an accurate physical exam. Knowledge of the relationships of the abdominal viscera is essential for making accurate diagnoses of the disease processes. Gastric reflux and duodenal ulcers are common clinical problems. Liver transplants and cholecystectomies, removal of the gallbladder, are common surgical procedures. The spleen is the most frequently injured abdominal organ, and its rupture can lead to fatal hemorrhage. Here are your learning objectives. You can pause the video and go through them, or look at the PowerPoint that you got from your learning management system. Knowing the arterial supply of the abdomen helps discern the gut derivatives. The main artery from where all of the blood supply comes is going to be your aorta. And the aorta, as you probably know, extends from T12 down to L4. L4 is the bifurcation of the aorta into the two common iliac arteries. The first artery of the foregut is going to be the celiac trunk. And then you have the superior mesenteric artery and inferior mesenteric artery that are respectively the arteries of the midgut and hindgut. The foregut extends from the esophagus to the point in the duodenum where the bile duct enters. It's kind of like about halfway down the second part of the duodenum. Then we have the midgut from the duodenum to the proximal 2/3 of the transverse colon, and the hindgut for the distal 1/3 of the transverse colon and the upper anal canal. The foregut is, as I've already mentioned, supplied by the celiac trunk, and what I haven't mentioned yet is that pain is referred to the epigastric region. The midgut supplied by the SMA, aka superior mesenteric artery, and pain is referred to the region around your belly button. And the hindgut is going to be supplied by the inferior mesenteric artery, aka IMA, and pain is referred to the hypogastric region, which is the region below your tummy region, so to say. Let's talk about peritoneum. The peritoneum is basically a serous membrane that will line the abdominal and pelvic cavities. This serous membrane secretes a kind of watery, slippery substance that helps keep the surfaces of the viscera moist, but it also helps movement because your gut actually, due to the muscles in it, can contract and move, and it has to do so to move boluses of food along on their journey. The parietal peritoneum will line the body walls, including the organs that lie on these walls, for instance the urinary bladder. These organs are referred to as retroperitoneal because they're behind the peritoneum. The visceral peritoneum completely surrounds the organs, like for instance most of the small intestine. These organs are going to be referred to as peritoneal. Peritoneal organs attach to the body wall by folds of peritoneum that are called mesenteries, or mesocolons, or ligaments, etc. The mesenteries provide means by which vessels and nerves can pass to and from the viscera. For example, the branches of the superior mesenteric artery that you can see here that are going to a lot of the small intestine. Peritoneal organs are more mobile than retroperitoneal organs because they are suspended from mesenteries. The retroperitoneal organs are not quite that mobile because they're just stuck behind the parietal peritoneum. The potential space between the parietal and visceral layers of the peritoneum is called the peritoneal cavity. Normally, it only contains a little bit of serous fluid, which keeps the peritoneum moist and allows the organs to slide past each other to some degree. The peritoneal cavity can be divided into two parts, a lesser sac and a greater sac. Here's the greater sac, and here is the lesser sac. The lesser sac here is highlighted in gray. The lesser sac is posterior to the stomach and posterior to the lesser omentum. It lies in front of or anterior to certain organs on the posterior abdominal wall, for instance the pancreas, shown but not labeled here. The greater sac, that is everything that is black here, is all of the remaining part of the peritoneal cavity. The lesser and greater sacs communicate with each other via an opening which is called the epiploic foramen. That is right here. In lab, if you're coming from the right side of the donor, you can actually put your finger right through this foramen and it ends up in the lesser sac. In doing so, and this is actually important to try out, you will have anterior to your finger the portal triad that contains the proper hepatic artery, the portal vein, and the common bile duct. As the greater omentum can move within the peritoneal cavity to seal off an inflamed area, for instance, as you can see here in B, an inflamed appendix, or in C, see it's actually adherent to the base of a gastric ulcer, we can say it's kind of the policeman of the abdomen. The greater omentum also cushions organs against injury and provides insulation to prevent loss of body heat. For descriptive purposes, the abdomen can be divided into 4 quadrants by 2 perpendicular lines. You have a horizontal line and a vertical line. That'll divide it into the right upper quadrant, left upper quadrant, right lower, and left lower quadrant. We can also divide the abdomen into regions. Like this, we would actually have 9 regions. And so we would have the epigastric region, umbilical region, and hypogastric region. Then we would have the right and left hypochondriac regions, the right and left lumbar regions, and the right and left iliac regions. Very rarely do we see an individual with a complete situs inversus, where basically the abdominal viscera is flipped from the normal layout, for instance here with the liver on the right and the stomach on the left, to exactly the opposite mirror image of this. Even the appendix is on the wrong side, so to say. This is something that should be in your minds when you are doing an exam, especially if it's for possible appendicitis. The probability of encountering someone with a complete situs inversus is quite low. However, it does happen. Before beginning a detailed discussion of the abdominal viscera, it might actually be helpful to get an overall view of their disposition in the body. Starting with the abdominal esophagus, right over here. It's a very short portion that joins the stomach just below the diaphragm. The stomach is a peritoneal organ that is continuous distally with the duodenum, the first part of the small intestine. The small intestine is the jejunum and the ileum. It's 3 parts. It consists of 3 parts. I already mentioned the duodenum. So it's the duodenum, the jejunum, and the ileum. Okay. They are pretty long altogether, about 7 meters, and their coils lie both in the abdomen and all the way down into the pelvis. Then we have the large intestine. The large intestine is the remainder of the GI tract. It's only about 1.5 meters long, but it's larger in caliber than the small intestine, as you can see here. The large intestine will consist of your cecum, with the appendix attached to it, the ascending colon on the right side of the abdomen, it's retroperitoneal, or actually secondarily retroperitoneal, the right colic flexure, also called the hepatic flexure, the transverse colon is peritoneal, the left colic, also called the splenic flexure, the descending colon on the left side of the abdomen, which is also retroperitoneal, the S-shaped sigmoid colon, it's peritoneal, the lower part of the abdomen and pelvis, the rectum The upper part is retroperitoneal, and the anal canal. Liver and gallbladder are peritoneal organs. They actually develop as outgrowths of the duodenum and are connected to it by a duct system. The pancreas is also an outgrowth of the duodenum, and it is connected to it, by a duct system. The pancreas is retroperitoneal. Today we're going to try to discuss in detail the organs that are derived from the embryonic foregut, namely in that case the stomach, the duodenum, the liver and gallbladder, the pancreas, and the spleen, which is actually not part of the GI tract, and it's also not derived from the foregut. Next up is the stomach. The stomach has different parts that will be your fundus, your body, and the pyloric part. The pyloric part can be divided into a proximal antrum and the distal narrowed pyloric canal. We also have the region over here, which is called the lesser omentum. That's a sheet of peritoneum that is attached to the lesser curvature along here of the stomach. And then there's a hepatogastric ligament that attaches to the lesser curvature, and a hepatoduodenal ligament that contains the portal triad that attaches from the liver to the first part of the duodenum. If you put your finger in here, as the arrow indicates, you will be going through the epiploic foramen and end up in the lesser sac. Anterior relations of the stomach are the left lobe of the liver, the diaphragm, and the anterior abdominal wall. On the posterior surface of the stomach, or actually if we lift up the stomach like this, the greater omentum has been cut and the stomach has been reflected superiorly. Posterior relationships of the stomach are going to be, you have the diaphragm, the spleen, the left suprarenal gland and the left kidney, the pancreas, and the transverse mesocolon, and then last but not least, the left colic flexure. Next, we're going to have a look inside the stomach. Inside the stomach here, we can see there's this zigzag Z line that is a junction of the gastric and esophageal mucosa. This is called the cardiac orifice. You have lots of folds in the stomach that are called rugae. Then you have the pylorus and the pyloric sphincter. Here's the pyloric orifice, and then you have the first part of the duodenum. The two orifices of the stomach are the one up here, the cardiac orifice, where it receives its food. It's called cardiac orifice because it's close to the heart. And there is a functional sphincter present in the region of the cardiac orifice. Its important function is to prevent reflux of food material and gastric juice into the esophagus. The esophageal mucosa is pretty vulnerable to gastric juices. That's why it's very important that there is a functioning sphincter in place here. The pyloric orifice on the other end leads into the duodenum, so part of the small intestines, and that opening is going to be surrounded by the pylorus or the pyloric sphincter, which is basically just a thickening of circular muscle layer of the stomach. Most of the time, the pyloric orifice is going to be closed when the stomach is digesting food, but the sphincter will relax intermittently to allow chyme to pass into the duodenum. Irritation of the sphincter by a nearby ulcer, for instance, can cause it to spasm, which will result in gastric retention and distension. Surgical division of the sphincter may be required, or a surgical anastomosis of the stomach with a jejunum can be performed, thus bypassing the sphincter altogether. This here just shows you a radiograph of the stomach and small intestine. So the stomach would be up here. Use the virtual laser. Here's the stomach. Then you can see how we continue through the pyloric region into the duodenum, and then from the duodenum to the jejunum, and continues all over here. That is after a barium meal or a barium swallow, which is added as contrast. Up there you can see air in the stomach. There's the body, and there's the pylorus. First part of the duodenum, jejunum, and next slide. This is about GERD, gastroesophageal reflux. Here's another radiograph of a barium swallow showing an esophageal stricture. So you can see right here, there's the barium contrast meeting the esophagus. Here's the thoracic bronchoaortic constriction. These are transverse processes of your vertebrae. This is what IV discs look like. They have less radio opacity. The phrenic ampulla is here, so it's about above the diaphragm. It's only seen radiographically. Then the diaphragm is going to be right here. And here's another constriction. It's a naturally occurring constriction, the diaphragmatic constriction. And then after the thoracic esophagus, of course, we have the abdominal esophagus. Yeah, important to note, acid reflux, so gastric reflux, causes inflammation of the esophagus, which can lead to really painful and also dangerous peptic esophagitis and stricture formation. We can subdivide the duodenum into 4 parts. First part, second, third, and fourth. All parts of the duodenum are retroperitoneal except the first part, which is therefore the most mobile. The parts and relationships of the duodenum, you don't need to memorize all of them, but it's important to have heard about this, are as follows. The first part, or superior part, inferiorly it's related to the head of the pancreas, anteriorly to the liver and gallbladder, and posteriorly to the common bile duct and the hepatic portal vein. The second part, or descending part of the duodenum, medially it's related to the head of the pancreas, anteriorly to the liver and gallbladder, also anteriorly to the transverse colon and mesocolon, and behind this, or posterior, would be the right kidney. The third part, or horizontal part, is related superiorly to the head of the pancreas, and anteriorly to the root of the mesentery, which you will see in lab actually covers this, so we can move it out of the way. Posteriorly, there is going to be the psoas major muscle, the IVC, and the aorta. The very short fourth part, the ascending part, is related to the root of the mesentery, anteriorly, posteriorly to the left psoas major muscle, and the fourth part also passes superiorly to join the jejunum at the DJ, or duodenojejunal flexure. Try repeating that 3 times quickly. Duodenojejunal. When we open up the duodenum, which was definitely what we're going to do in lab, we should be able to identify the major duodenal papilla right here. This is where we have the union of the main pancreatic duct and the common bile duct enter the duodenum. Here is the SMA kind of like poking through. That's going to cross over the duodenum. Speaking of the SMA and the duodenum, there is a symptom called SMA syndrome or nutcracker syndrome. This is a lateral view. So you can see here's the superior mesenteric artery, and it hangs down. If there's too much traction, you would actually have compression of the left renal vein, but also you can have compression of the duodenum, so the third or horizontal part. So you can imagine that that is bad, because of course the return from the left renal vein is going to be occluded. That will also mean that the return of the left gonadal vein is going to be impeded, because that actually drains into the left renal vein. And in addition, if we have pressure on the duodenum here, that means that food cannot actually keep passing through it. So symptoms could include nausea and vomiting because of the duodenum. Okay, food is not going to be able to pass through the duodenum and will back up in the stomach. Now we get to learn something about the liver. The liver is actually the largest gland in the body. It is 1/40th of the total body weight in an adult, 1/20th of the total body weight in a newborn. The liver is said to be the most vascular organ in the body. Because of its softness and vascularity, injuries to the liver result in pretty severe bleeding. The liver performs mainly or many important functions. For instance, the secretion of bile, which then gets stored in the gallbladder. Bile is important for instance, digesting fats. It's important for the secretion of hormones, important for metabolism of products of digestion, metabolism of drugs and toxins, synthesis of serum proteins and lipids, elimination of old cells and particulate matter from blood, and production of blood cells during fetal life, that is. Needless to say, the liver is essential to life. Nevertheless, it has been estimated that about 1/3 of the liver is adequate to maintain normal function. The relations of the liver are as follows. you probably know that the liver lives mainly in the right upper quadrant. It has two surfaces which are separated by a sharp inferior border. The fundus of the gallbladder projects below the inferior gallbladder, down here. The diaphragmatic surface is going to be smooth and convex. Through the diaphragm, the liver is related to the bases of the right and left lungs. Hepatic abscesses, for instance, in the liver might perforate the diaphragm and can even enter the pleural cavities and bases of the lungs. The diaphragmatic surface is going to be separated into right and left lobes by the falciform ligament going down here. And you can see the ligamentum teres hepatis that contains the obliterated umbilical vein, also called the round ligament of the liver. Remember, the teres means round. You also have the coronary ligament up here that is also a reflection of peritoneum from the liver onto the diaphragm. At its right and left extremities, the coronary ligament ends as the right and left triangular ligaments. If we flip it over, we can see the visceral surface of the liver, and there are the different lobes. Let me add in all the labels for us here. So the visceral surface of the liver shows the impressions of the organs that are related to it. The right lobe is going to be related to the right kidney and the suprarenal gland, the right colic or hepatic flexure, and the duodenum. The left lobe is related to the abdominal part of the esophagus and the stomach. The visceral surface also has caudate and quadrate lobes, and the quadrate lobe is four-sided. Remember, quadratus means four-sided or square. The caudate lobe is so named because it has a caudate, which is a tail-like process, not because of its position, which is cranial to the quadrate lobe. You can see we can superimpose something that looks a little bit like the letter H onto the posterior surface or the visceral surface of the liver. So these four lobes of the liver can be separated by a pattern of fissures and sulci, which resemble the letter H, or more or less the letter H here. These fissures for the ligamentum venosum and the ligamentum teres form one vertical bar of the letter H. The sulci, or grooves, for the IVC and gallbladder, over here, form the other vertical bar, and the cross of the H is termed the porta hepatis, which means gate of the liver. The porta hepatis is where branches of the proper hepatic artery, portal vein, and common hepatic duct enter or leave the liver. In addition to the anatomical lobes of the liver, the right and left functional lobes can be recognized. Each functional lobe is then further subdivided into lateral and medial subdivisions, which in turn, yes, again are divided into segments. This is important because the division of the liver into functional lobes, etc., is based on the branching and distribution of the hepatic ducts, hepatic arteries, and portal vein. Since each of the 8 hepatic segments, 1 through 8, has its own blood supply and biliary drainage, it is possible to surgically resect an individual segment which might be damaged by injury or disease. Here we are superiorly reflecting the liver a little bit. We're going to be doing something similar to that in lab. Remember that the lesser omentum, which is visible right here, is basically a double-layered sheet of peritoneum. And it has two parts, the hepatogastric ligament from the liver to the lesser curvature of the stomach, and the hepatoduodenal ligament from the liver to the first part of the duodenum. Posterior to the free edge of the hepatoduodenal ligament is the epiploic foramen, back here. Put your finger in there and then you can feel the portal triad anterior to your finger. Embedded within the hepatoduodenal ligament, i.e. between its two layers, can be seen the common bile duct, the portal vein, and the proper hepatic artery as they course towards the porta hepatis. The mnemonic for remembering the relationships of the structures within the hepatoduodenal ligament: ductus dexter, duct on the right, portal posterior, vein behind, and hepatic artery proper is on the left. This is a pretty nice cadaveric picture. You can see the contents of the hepatoduodenal ligament, a gross anatomical image. Here is the proper hepatic artery. There is the portal vein and the common bile duct. The proper hepatic artery is a branch off of the common hepatic artery, which is going in this direction, and the artery going down here towards the stomach and the duodenum is called the gastroduodenal artery. Gallbladder. Bile is produced by the liver up here and then stored in a concentrated form by the gallbladder. It is then released, for instance, after a fatty meal, and the release of bile from the gallbladder is under the influence of an important hormone called CCK, or cholecystokinin. This hormone is produced by the mucosa of the duodenum after gastric contents reach it. In addition to causing contraction of the gallbladder, the hormone relaxes the sphincters around the hepatopancreatic ampulla, common bile duct, and main pancreatic duct. Thus, bile and pancreatic enzymes reach the duodenum. Here's a nice illustration of the duodenum and the gallbladder and their relations to each other. Up here is the cystic duct with a spiral valve that is controlled by CCK. Here's the common bile duct. And here's the hepatopancreatic ampulla of Vater. And this little region in here is called the major duodenal papilla. There's also a minor duodenal papilla for the accessory pancreatic duct. Please also note here the dashed line. It goes right about across where the major duodenal papilla is. That is the transition from our foregut to the midgut. Gallstones. Clinical significance of the close relationships of the first and second parts of the duodenum to the gallbladder. If the gallbladder becomes inflamed because of impacted gallstones, for instance, it can adhere to the adjacent parts of the GI tract, duodenum and transverse colon. Tissue can break down and a fistula can develop. Large gallstones could then pass into the duodenum and become lodged at the ileocecal valve, with consequent bowel obstruction. Gas from the GI tract could also pass into the gallbladder via a fistula, providing a diagnostic radiographic sign. Here are your gallstones, and here's the gallstone stuck in the cystic duct. There will be cholelithiasis. If it's just an inflamed gallbladder, that's cholecystitis. Here's the gallstone then stuck in the cystic duct. It can also get stuck down here in the common bile duct. And the other places, if there's a formation of a fistula, there are other places where it can end up. Next up is the pancreas. It has a head, neck, body, and tail. See, the tail extends all the way over and tickles the spleen over here. This is a little bit cut off down here. T, a little bit of the T for tail. Retroperitoneal organ, per se. And posterior to the pancreas, we can find the following: the inferior vena cava, the aorta, the splenic vein and the inferior mesenteric vein, the formation of the portal vein, which we can actually see in cross-section here. The origin of the superior mesenteric artery is behind it. Here it is poking out underneath it. And the common bile duct. The pancreas is both an exocrine and endocrine gland. The exocrine part will secrete digestive enzymes like protein, carbohydrate, and fat-splitting enzymes. These will reach the duodenum via the main and the accessory pancreatic ducts. These ducts will open into the second part of the duodenum, important to remember, at the major and minor duodenal papillae, as I noted earlier. The main duct has a kind of herringbone appearance since it receives obliquely oriented tributaries as it passes toward the duodenum. Here's a little histological image for you. The endocrine functions of the pancreas, as probably everybody knows, are the secretion of insulin and glucagon to regulate carbohydrate metabolism. The cells that secrete these hormones are located in regions that are called the islets of Langerhans. And the pancreas has a pretty rich blood supply in keeping with its endocrine function. The acini that are all over here are made of cells which secrete the digestive enzymes. Next is the spleen. The spleen plays multiple supporting roles in the body. It acts as a filter for blood as part of the immune system. Old red blood cells are recycled in the spleen, and platelets and white blood cells are stored in there. The spleen is intraperitoneal. It is usually found approximately at the level of the 9th to 11th rib. The hilum is the region where vessels enter and exit it, and the relations of the spleen are to the stomach, the left kidney, the left colic flexure, and the tail of the pancreas. Here's just a CT scan of splenomegaly that's pretty easily identified on a CT scan. You can see a normal spleen would actually have the size of a fist, but it can quite greatly enlarge. That is then called splenomegaly, of course, due to portal hypertension, for instance, secondary to liver cirrhosis or other liver diseases. Other causes of splenomegaly would be malaria, Hodgkin's disease, leukemia, heart failure, cirrhosis, as I've already mentioned, tumors in the spleen or from other organs that have spread to the spleen, and in addition to all these, also, of course, viral, bacterial, or parasitic infections, inflammatory diseases such as lupus or RA, so rheumatoid arthritis. Blood supply to the foregut. The celiac trunk arises from the abdominal aorta at the level of T12, just inferior to the diaphragm. The celiac trunk is a very short artery that will trifurcate into the following branches. The left gastric artery is the smallest branch of the celiac trunk. It ascends retroperitoneally toward the lesser curvature of the stomach. It gives off an esophageal branch to the abdominal part of the esophagus. The left gastric artery will then run along the lesser curvature of the stomach, supplying it on both surfaces. Another branch coming off here is the splenic artery. The splenic artery is actually the longest branch of the celiac trunk, and it takes a really tortuous or curly-whirly course toward the spleen. It also runs retroperitoneally along the upper border of the pancreas. When it reaches the left kidney, it passes into the splenorenal ligament to reach the hilum of the spleen. Here it will then divide into splenic branches, and these branches do not anastomose with the spleen or within the spleen, so that a vascular segmental distribution within the spleen occurs. The rich blood supply of the spleen is also coupled with its thin capsule. That means that if the spleen is ruptured due to trauma, as we saw on the football player a few slides ago, it'll result in really severe hemorrhage, which is often life-threatening. In addition to the spleen, the splenic artery helps supply the stomach via short gastric arteries to the fundus and the left gastroepiploic artery to both surfaces of the greater curvature. The left gastroepiploic artery, which runs along here, supplies the left part of the greater curvature of the stomach. The common hepatic artery, which we can see coming off here and going towards the right, will divide like the letter T, kind of lying on its side, tipped over to the right. It divides into the proper hepatic artery and the gastroduodenal artery. The proper hepatic artery will run toward the porta hepatis of the liver within the free edge of the lesser omentum, which for this view has been removed. It gives off the right gastric artery, which makes a pretty sharp bend to reach the lesser curvature of the stomach, which it supplies again on both surfaces, and which anastomoses with the left gastric artery. At the porta hepatis of the liver, the proper hepatic artery will divide into right and left hepatic arteries up there, which will then supply the right and left functional lobes of the liver. Usually the cystic artery to the gallbladder will arise from the right hepatic artery within the cystohepatic triangle. It's also called the triangle of Callot, more later. The gastroduodenal artery will pass posterior to the first part of the duodenum, and then it'll give off the right gastroepiploic artery, that's synonymous with right gastroomental artery, which then supplies both surfaces of the greater curvature of the stomach, as well as the greater omentum before anastomosing with the left gastroepiploic artery. So you have the right and left gastroepiploic arteries that do the greater curvature of the stomach, and the right and left gastric arteries for the lesser curvature of the stomach. The GDA, or gastroduodenal artery, also gives off another artery which has a long name. It's called the anterior superior and the posterior superior pancreatico-duodenal arteries, well, they will supply the head of the pancreas and the duodenum. Here's a celiac angiogram for you. If you pause this, see if you can figure out a couple of the branches. I'll give away this one, that's probably the easiest one. That is your splenic artery. So the celiac trunk would be here. And here's your common hepatic artery. Let's see if you can make out which one would this one be going upwards, and this one going down. Well, going up would be the proper hepatic artery, then the right and left hepatic arteries, and the large one going down here should be the GDA or gastroduodenal artery. In addition to that, if we follow this a little bit further, this seems to be tracing the greater curvature of the stomach, so we can say with quite some sincerity that this would be the right gastroepiploic artery that then turns into the left gastroepiploic artery. Now let's review the blood supply from the celiac trunk. We have our common hepatic artery, our splenic, and our left gastric artery. We have our right gastric artery, the proper hepatic, that actually splits into the right and left hepatic arteries, of course. Then you have the anterior and posterior superior pancreatico-duodenal arteries. There are inferior ones as well that come from the SMA. And you have your gastro-omental artery from the right and gastro-omental artery from the left. Left gastro-omental, right gastro-omental. Gastro-omental is interchangeable with gastroepiploic artery. The right gastric artery supplies the lesser curvature of the stomach. The left gastric artery does the same. The gastroduodenal artery that we can see coming down here has the right gastro-omental artery that will supply the greater curvature of the stomach and the greater omentum. It also has the anterior superior pancreatico-duodenal artery that supplies the anterior duodenum and the pancreas. And it has the posterior superior pancreatico-duodenal artery that supplies the posterior duodenum and the pancreas and also the lower part of the bile duct. The proper hepatic artery is just the continuation of the common hepatic artery after the gastroduodenal branches off. It'll then branch into the left and right hepatic arteries that supply the left and right lobes of the liver. It also has a branch that goes to the gallbladder called the cystic artery. And actually the cystic artery supplies not just the gallbladder but also the upper biliary system in general. The splenic artery, the biggest and longest and curliest that we have, will supply the spleen, but it also gives rise to the left gastro-omental artery. And it also has pancreatic branches, so several branches that come off on its way to the spleen that supply the pancreas. Here's a review slide for you. And I would like to thank you for your attention.